morning, everyone. Thank you so much for joining me this morning, this early morning. This is the first meeting under this series about mock Viva, like a practice in which I'm going to ask you questions and comment on your answers. So it is exam-oriented and interactive. I am Dr. El-Abedin, a lecturer of ophthalmology in Viva University Hospital and also a professor at Samy Virtual University for postgraduate ophthalmologists. Please view me as a moderator or like a facilitator rather than information provider. So it is a time for practice. So we can learn together and practice together, okay? Of course, you as the candidates, you all have the same goal, which is a great goal, by the way, to pass the final FRCS exam on the first attempt. We have an exam coming soon in 1 month in Bangalore. So I hope you will find this presentation useful during your preparation for the exam. And I started by the experience provided by Dr. Samy. This is a very recent experience. Her exam was in Mumbai, 2022, and some of you have been assigned for some questions. So as you know, this is the first day of 2023. And I want to remind you, it is a common practice and it is advised to have a journal or agenda to set your goals. And try to use this SMART goals, SMART technique. So regarding our goal now to pass the exam, so this is a specific goal and you have to make a timetable. So this is for T actually. It is a attainable goal, by the way, because many achieved this goal. And it is also relevant to our practice. So passing the exam also motivates us to improve our practice, in addition to promotion, job promotion, and improving your resume. All right. So I posted this before, so I recommend to take notes during the presentations. Whenever you feel that you have to rehearse or restudy or revise something, please write down this topic because all the questions presented are high-yield questions. So please take notes. Sometimes we have the knowledge, but at the time of the Viva station, we stumbled or we start under the stress to lose information. So that's why practice is important, at least once or twice, whether with me now or with your study partners, in order to speak with power and confidence. So practice is an essential step during the preparation. So this presentation depends on your interactivity and your answers. All right. So be involved, not entangled. So be involved right now before you entangled at the exam. So it is a kind of play, we will play like acting. So I will act as an examiner. So I'm a national examiner. I'm not an FRCS examiner. So I'm a national examiner. I've been examining students, undergraduate and postgraduates, for more than 1 decade. So I will play the role of the examiner and you will play the role of the candidate. But of course, the practice right now is a bit different from the exam because you already have an idea about the questions. It is not time bound. So you will have time to think and to guess, and we will get a spontaneous correction from my side. But actually in the exam, some examiners stop you whenever you say something wrong or whenever you drift away from the correct answer. But other examiners will leave you to speak whatever you want. Some questions are actually will go beyond the exam in order to improve the clinical practice. So there is some clinical practical questions as well. Again, you have time to think and to guess, and perhaps you may reflect on the information provided. Also, I'm expected that your knowledge is better than mine because I don't know if you know me, but I'm a strabismologist. So now I'm speaking out of my comfort zones. Over the last years, I am focusing on strabismus only and ocular motor disorders. All right. So now I will choose one of the participants to answer one of the assigned questions. During the answering, I will comment on the answer. It's like to and fro, like one-to-one discussion. And then I will show you some slides related to the topic and some predicted questions. Okay? So we have 4 participants today, hopefully. And let's start by the first one. First of all, are you stressed right now? While you are thinking or you are reflecting on this image, I want to say something. Sometimes the Viva station starts by an image like this. So somehow it looks like a clinical station. It reminds us by the clinical station, because in clinical station, the first and the most important and crucial point is to pick the signs. If you miss the signs, actually you are risking your score, you know? So if the Viva starts by an image, it's really important to pick all the signs and don't miss the signs. And perhaps you will come up with the diagnosis or a list of differential diagnosis. So, and also don't expect a high quality images all the time, because some previous candidates complained about the quality. They are not good enough, because sometimes they enlarge the image and it gets pixelated. And it is printed image, by the way. I hope in the future they will present images in a soft copy. So Dr. Tamanna, kindly, the first question describes the findings in this image.
This is a color photo of the anterior segment of the eye. The eye looks like the left eye. The picture shows a cystic elevated bleb in the upper quadrant. The pupil is mid-dilated. The conjunctiva appears to be normal. The cornea is clear. I can also see mild the thickening of the eyelids, probably a tylosis. So this could be an old person. My diagnosis would be post-trabeculectomy bleb.
Okay, excellent. I shall comment now. So I will start by something trivial, like something unimportant, because we are practicing to be very observant, right? So you said all the age. So this is very good to comment on the age whenever possible, because sometimes in the differential diagnosis varies with the age. So some saying the differential diagnosis for child is different from for an adult, right? So you said thickening of the lid margin or tylosis, and also there is poliosis, right? Poliosis. There is whitening
Yes.
of the eyelashes. See, so this is supported your answer, your guessing. Actually, it is a guessing. And you can also add, we are talking in general, but these comments are not important, actually. And you can comment on the complexion. So this is a white complected person or patient, because we have a gray color iris and the skin looks fair, okay? Again, we are talking in general, because some diseases are linked to the complexion, to the color. And you see here a remnant of something orange. What is this orange colored fluid? Or
it could be a fluorescein staining.
So yes, it should be a fluorescein staining. So here again in the eyelashes here. What is the uses of the what are the uses of fluorescein in the setting of a patient with a previous history of trabeculectomy?
Fluorescein staining is mainly done to detect any wound leakage in the post-operative period, and also to look for any corneal epithelial erosions.
Okay. Can you elaborate more on the leakage? How we detect leakage by using the fluorescein?
When you apply fluorescein, if there is a leakage, you can see egress of aqueous with lining of fluorescein on either side.
Okay, and what is the name of this test?
Seidels test.
CDAL test. So CDAL test positive. You are looking for a positive CDAL test, and so you need fluorescein. And what type of illumination you use? Illumination.
You do the illumination with the blue filter.
So cobalt blue. Okay. So this is a full
Cobalt
answer.
blue filter.
Okay. How about the PI in this case? Peripheral iridectomy or iridotomy?
I cannot see the peripheral iridectomy clearly in the picture.
So you can add, so sometimes mentioning the negative is important. When the negative is, or sign is negative, or you couldn't see, you can comment on some relevant signs. So you can add, I can't see the PI, probably it is masked under the blip. Okay? And
okay, ma'am.
So, and also you can add, this is a quiet eye, so there is no inflammation. And when you are now we are commenting on the more important points. So when you are commenting on the blip, have you commented on the height of the blip?
It is slightly elevated, a vascular blip.
Is it vascular?
I cannot comment on the.
Is it vascular?
A vascular blip. I cannot comment on the microcysts in the picture.
Because it's not slit beams, it's fused illumination. So this patient actually has a past history of trabeculectomy. So do you think it is trabeculectomy only or augmented trabeculectomy?
Since he has a past history of failed trabeculectomy, it could be an augmented trabeculectomy.
So what does it mean, augmented?
With augmented trabeculectomy, we will use either 5-fluorouracil or mitomycin C. These are antifibrotic agents.
Okay. Excellent.
So, okay.
Yes. Actually, I didn't say failed trabeculectomy. I said the patient has a history of trabeculectomy. Actually, what supports the use of antimetabolites is the high cystic blip and avascularity. So whenever you have a large cyst like this, thin-walled, and avascularity, this suggests the use of antimetabolites. Okay. And as you can see here, this is also not important, but here the examiner retracts the upper eyelid. Okay, so the examiner, this is a practical point. So the examiner should retract the upper eyelid to look for the hidden places. So we consider the superior limbus and the upper bulbar conjunctiva as a hidden places. So this is relevant in clinical station. So in clinical station, you have to retract the upper eyelid and the lower eyelid because you can miss any sign in this area because this is hidden. So imagine now the patient underwent have blip and peripheral iridectomy and you didn't retract the upper eyelid, definitely you will miss the signs. So this is one of the hidden places you have to search in your clinical station. Also the lower lid. Sometimes the lower lid is hiding the lower limbus. So you may miss signs like early hypopyon or any sign in the lower limbus. And also you have to retract the lower lid to look at the fornix and the inferior bulbar conjunctiva. So don't forget the hidden places in your clinical station. All right. And you said, excellent, you said the cornea looks clear because you are seeing the details of the iris and the cornea reflection is bright and will form. How about the anterior chamber depth?
In this picture, it is difficult to comment, but I assume it should be normal.
Okay, so it's
or slightly shallow.
Yeah, yes. Because of absence of the slit beams, so it's hard to comment on the anterior chamber. So if I'm saying now the anterior chamber is a little bit shallow, so what is the next step?
Okay. Since the anterior chamber is shallow, my next step would be to check the IOP, intraocular pressure.
Okay, so you want to check the IOP, and the IOP is found to be
5 millimeter mercury.
And the next step is CIDAL test. I think you said it.
CIDAL test was negative.
So
okay.
What's the next step in the examination? What are the points to be examined also in the eye? We're still in assessing the patient clinically.
Sorry, ma'am, I didn't get your question.
What are the points to be examined in this patient? In addition to anterior, so we commented on the anterior chamber, it's shallow.
And we have negative sedal test and high blip and low IOP.
Okay.
Are there any things in the eye to be checked before management, before treatment?
I would assess the patency of the iridectomy and the ostium by a gonioscopy.
Okay. It's expected to be patent because actually we are checking the patency of iridectomy if we have a high IOP because we are suspecting of pupillary block. And so you are trying to avoid like much manipulation in such eye, right? So you can jump into the posterior segment, right?
I would check the posterior segment for any choroidal detachments, hypotonous maculopathy.
Yes, you are searching for the complications of hypotony. Okay, so this is very relevant. Okay, so suppose the patient has like something obscuring the view of the fundus, let's say cataract. So it's really necessary to check the posterior segment by ultrasound, okay, to search for complications of hypotony or causes of hypotony.
So the diagnosis of such a case is an overfiltration bleb, since we have shallow AC, low IOP, negative sedal test, and high bleb. And of course, the use of antimetabolites increased the risk for having such an overfiltration.
So before you started the treatment, what is the problem of hypotony? Or do you know the definition of hypotony, by the way?
When the intraocular pressure is less than 6 millimeters of mercury, it can result in hypotony.
And what are the complications of hypotony?
Hypotony can cause maculopathy.
Hypotenuse
in long-standing.
Yes, and
disc edema.
Disc edema. So it is like oozing.
Choroidal folds.
And the
choroidal folds.
Choroidal folds, excellent, and corneal edema. So every like
corneal edema.
Yes, corneal edema also. So it's edema in everywhere. All right. So regarding the management, you can check the management from your textbook. Okay, I'm not asking about the management. That's not because you already picked the sign. Okay, you said the diagnosis, so you know that this is a blip because you were assigned for trabeculectomy question.
Okay.
But sometimes this cystic change can happen with like previous surgery, other surgery other than trabeculectomy. But because your mind already prepared that you are going to be asked about trabeculectomy, so you told us the diagnosis. But it's okay, it's fine.
Okay.
So stay with me, okay? Here is a question. What are the complications of trabeculectomy?
The complications of trabeculectomy can be divided into intraoperative complications, early postoperative complications, and late postoperative complications.
Okay, excellent. Excellent. But in general, because we are practicing in general, so whenever there is an operation and the question is about the complications, you have to start by anesthesia complications, okay? So try to be in your mind, there is pre-operative, operative, and post-operative, okay? And in the pre-operative, it is actually the anesthesia complications, okay? So because sometimes when it comes to cataract surgery, they like to ask about the anesthesia complications, okay? But here in trabeculectomy, we are concerned more about the post-operative complications, actually. But generally, if my question is, if the question is about complications in general, you have to start by anesthesia complication, operative complication, and post-operative complication. And well done, you said early and post-operative complication, and this is very important when it comes to trabeculectomy, and when it comes to cataract surgery, we have like early in the early post-operative period, and we have late in the late post-operative period. So now let's start by just enumerate the early post-operative complications.
The early postoperative complications can be with shallow anterior chamber with increased IOP and decreased IOP. The causes for shallow anterior chamber with decreased IOP would be overfiltration, wound leak, and ciliary body shutdown. If the IOP is high, it could be a pupillary block, a malignant glaucoma, yeah, and also there can be bleb infections also.
Okay, and what about the late post-operative complications?
Late bleb leakage,
Yes.
blebitis, endophthalmitis, fibrosis of the bleb, failure of filtration.
Excellent, excellent. So now fill in the gaps. Can you read this sentence?
In the early postoperative period, the most common complication faced by the surgeon involved either an increase in the IOP or a decrease in the IOP.
Excellent, excellent. So here, according to the style of this question, there is no place for shallow anterior chamber, because you have to, because if you dissect the causes for hypotony, you will find what you already said. So what you already said actually is under the heading of hypotony and elevated IOP. But according to this style of question, it is either hypotony or elevated IOP. So both are bad, right? But which one is the most dangerous?
Hypotony.
Hypotony, yes. Hypotony is much more dangerous than elevated IOP, because remember, it is glaucomatous in the first place. So if we have an elevated IOP, we can think of another repeated surgery or whatever, but hypotony sometimes it is very resistant and you have to manage promptly. Okay.
Okay.
And here, can you comment on the bleb in this photo? The location
Just the
of
bleb,
the bleb,
ma'am.
the location of the bleb.
It is superiorly.
Yes,
I think it is the supranasal quadrant.
Okay, so my question is, this is so when you do trabeculectomy, is it better to do at 12 o'clock or like 10 and a half, like in the quadrant, like oblique? Is it better to do the trabeculectomy here at 12 o'clock or here or an oblique dimensions?
I'm not sure, ma'am, but I think it is the 12 o'clock because it will be covered by the eyelids.
But here it's also covered by the upper eyelid.
Yes. I don't know, ma'am. I'm sorry.
No problem. So, glaucoma surgeons, I'm not glaucoma surgeon, so glaucoma surgeons prefer to do it like upper nasal or upper temporal, because if they do it at 12, this area will be scarred. So in case of failed trabeculectomy, there will be little place for another trap. But if they started by one quadrant like upper nasal, and this failed, they can go to the upper temporal in the second sitting. Okay. So actually, according to this bleb is an ideal location, but it's flat, right? It's flat. So,
yes.
So don't forget that whenever you have a photo of a bleb, you have to comment on the extent and the height, vascularity, the wall, and so on. Okay. And how about the anterior chamber here in this case?
The anterior chamber is shallow.
So try to impress me, because we have grades for anterior chamber shallowness. So what is the grade here? So actually, in the exam, don't ever try to impress the examiner. Just say what you know. Don't show off your knowledge. Okay. But here we are practicing, so we are free to talk whatever we say. So here we have grading for the shallow anterior chamber. So what is the grade here?
Von Erich's grade 2, maybe?
No. Von Erich's grade is grading of the angle of the anterior chamber. So we have grading for the angle of the anterior chamber, and we have grading of the depth of the anterior chamber. So actually this was written in old Kansky, but I think it is omitted in the new canal speed. So we have 3 grades for shallow anterior chamber. Okay.
Okay.
Shall I say it or no? So
I can say it, ma'am.
So we have grade 1 when we have a position between the back of the cornea and the periphery of the iris. Okay. And the grade 2
Okay.
when we have a position between the back of the cornea and the pupillary border, like in this photo. And
Okay.
and the grade 3, which is the severe one, the most severe one, we have opposition between the back of the cornea and the lens, whether the human lens or the IOL or the anterior vitreous phase. So the more the grade, the severity is. Okay. So this is grade
Okay.
2. Grade 2 because we have, as you can see here, opposition between the whole iris and the back of the cornea. But still there is a shallow space between the lens and the back of the cornea. So this is grade 2. Okay.
Okay. Okay.
And actually, this is like inflamed and flat bleb. So this is a non-function bleb. So we have to, and we have shallow anterior chamber. So now we have a shallow anterior chamber and the flat bleb. What is your differential? And low IP.
It could be.
And low IP. So we have hypotony, and we have shallow anterior chamber, and we have flat bleb.
It could be a wound leakage.
Bleb leakage. Why you didn't say overfiltration?
Because in overfiltration, the blood will be high.
Excellent, excellent. So already you know the list of shallow anterior chamber with low IOP, but in order to differentiate, you look at the bleb height, you look at the CDAL test. So here in this photo, the bleb is flat, so this suggests bleb leakage. So you have to do CDAL test. And you can also, there are some signs also unimportant. We have suture still there, and we have irregular pupil, and this is mostly a pseudophakic patient.
Pseudophakic.
So this is another case. Do you think here is my question. Do you think the IOP is low or high in this case?
Most since there is corneal edema, the IOP could be low.
But in high IOP, the cornea is edematous. You know, one of the signs of high IOP is the corneal edema also. So now I am confusing you. So this sometimes happens in the exam. So I'm confusing you to test how the depth of your knowledge, how you are confident. Some candidates complained about this, but this is important. As an examiner, I want to test I want to test your confidence. So corneal edema can occur with high IOP and low IOP. Why you said low IOP in this case? So as you can see, the corneal is thickened, so definitely there is corneal edema. So your answer is correct. Your answer is correct. And this is shallow anterior chamber, but again, shallow anterior chamber, we can have high IOP with shallow anterior chamber, like in malignant glaucoma. But this is not the answer. Because shallow anterior chamber and corneal edema could be with high IOP or low IOP also. Okay?
Okay.
So the corneal edema due to high IOP is different in the morphology from corneal edema due to low IOP. So in hypotenuse eye, this is actually a hypotenuse eye. We will find this decimate folds. You see this corrugation? This corrugation suggests low IOP. The eye is like a shrunken, okay?
Okay.
So the pattern of the edema, the morphology of corneal edema due to high IOP is different from low IOP. Okay, so in high IOP, you will get the vesicles, you know, some vesicles like epithelial edema. But your answer is correct. So remember, I asked you about the complication of hypotony. So we mentioned together corneal edema. You can add and dismiss this. Okay.
Okay.
And what is this? Another complication of hypotony. So you see the choroidal folds.
Folds.
They are very subtle, but they are there. Okay. And also disc edema. So we have posterior segment complications of anterior segment surgery. And what is this? You answered this before. This is
This Seidl's test.
You can add positive Seidel test. So you have to add positive because Seidel test alone may be negative or positive, but this is a positive Seidel test. Okay.
Okay.
And this is, by the way, it's called the green river green. So river green, and this is analogies. Don't say analogies in the exam. Like any analogy, this is to make fun during studying or during teaching, but don't say analogies in the exam. Again, here is the summary of the complication of hypotony, choroidal falls, choroidal detachment, and the cause here is bleb leak. Are you still with me, Dr. Tamanna? This is a question from Kansky Test Yourself Atlas. So here is a question: what treatment has caused disease complications? So please answer number 3. It is not related to your question, but answer question 3.
Yeah, it is an inverse hypopyon or emulsified silicon oil following a retinal surgery. Hyperleon.
Okay, excellent. So the first word is what? Say it again.
Inverse hypopyon.
We usually say inverted, but inverse.
Okay.
I think inverse is correct also. And how about number 6, because this is relevant to our question. What treatment has caused this complication?
Probably augmented trabeculectomy with mitomycin C.
Yes, excellent. So when you see this thin-walled cystic bleb, you think of antimetabolites and also avascularity. And you know all that there are some or a lot of glaucoma studies. I don't know if they are important or not, but every now and then you may get a question regarding studies. But I brought this image because sometimes in order to make the study more palatable and much more easier, you can by study notes, like making a notes, try to by diagrams, try to summarize the findings, the question asked in the study, and the conclusion. So this is a question I found it in one of the presentation. Definitely, this is an advanced glaucomatous cupping. Okay, so there is a study called AEGIS IOP, so Advanced Glaucoma Intervention Study. So what is the cutoff for patients with advanced glaucoma? So what is the IOP? Sorry, what is the IOP cutoff for patients with advanced glaucoma to be likely stable? According to the study, actually the answer is 14 millimercury. So in early teens. So in early, if you guessed and said early teens, this is considered the correct answer. But according to the study, the cutoff is 14. So they are trying to decrease the IOP to 14 or less. And here is a question also for you, and this was taken from this video from CyberSide. So trabeculectomy is very one of the common procedures, and you have to know the steps, of course. Okay, and we have conjunctival flap, one of the steps. So, and we have 2 types of conjunctival flaps, right? We have limbal-based and fornix-based.
And fornix-based.
So in this photo, which one the surgeon perform? Is it limbal-based or fornix-based?
Fornix-based. Because I can see the incision is being done at the limbal area.
Okay, what is this? So
it is a limbal based. It's limbal based.
So please don't confuse. But actually, this is the flap, the conjunctival flap, and here is the incision. So it's limbal based. So the name is opposite to the incision. So limbal base actually is a fornix incision. Okay. So sometimes some learners confused, and it's confusing. So have you done trabeculectomy before, Dr. Tamanna?
No, ma'am.
Okay, we usually start by limbal incision. So most of us do fornix based actually, but in this video, this is limbal based. And you have to know the advantages and disadvantages of each one. Okay.
Okay.
So this is limbal based. Again, from the same video, the professor recommended this. This is a successful case because the bleb is diffuse, as you can see. So actually, diffuse is a good thing, but here, if it is localized and cystic like this is not recommended. This is not good bleb because they are more liable to trauma, discomfort for patient, and also leak, or perhaps if the IOP is high, this is called the ring of steel, like there is fibrosis surrounding the bleb. So she advised the creation of like diffuse bleb by the use of mitomycin over a larger area. Anyway, and again in this photo, don't forget that there might be more than one sign. So this is a case of Trab, and here's a PI, and also here there is a cataract. It could be due to previous attack of high IOP like glaucom flicking, or it could be due to previous episode of hypotony. So we forget the cataract. So cataract also one of the complications of hypotony. Okay, with shallowness of the anterior chamber, perhaps the lens contact with the lens contact with the cornea. This may induce cataract. Okay. And Dr. Tamanna, we have the most commonly used antimetabolites.
5-fluorouracil and mitomycin C.
And why the image of mitomycin is smaller than the image of 5-FU?
Probably we use less concentration of less amount of mitomycin C compared to 5-fluorouracil.
Yes.
I don't know.
Yes, excellent. So, and why we are using less concentration or less duration for mitomycin compared to 5-FU?
Because mitomycin C is said to be more aggressive than 5-fluorouracil.
So, so aggressive is an aggressive word actually. So you can say more potent or more effective, more powerful than 5-fluorouracil. And why mitomycin is more potent than 5-fluorouracil?
I don't know,
because they affect they suppress the cell cycle of the fibroblast as non-cell specific, like it acts in all phases of the cell cycle, but 5-fluorouracil acts only on the S phase. There is something called S phase in the cell cycle. S phase. So S phase is S for synthesis. Okay, so 5-fluorouracil affects
DNA synthesis.
Yeah, affects some certain population of fibroblasts, but mitomycin affects all fibroblasts. Okay, because it is non-cell specific. Okay. Mitomycin is non-cell specific. Anyway, and you have to know about the concentration. And remember, 5-fluorouracil is a solution, and you have to know the percent. And by the way, it is 5%. But mitomycin is a vial, it is powder. You have to make a solution from it, okay? And you have to know when we use the antimetabolites, some surgeons nowadays use it as a routine, okay? So imagine now we have an eye with high IOP, and you are going to do a surgery like Trab or cataract. What are the problems associated with sudden decompression of an eye with an elevated IOP?
There could be a suprachoroidal hemorrhage.
Yes, it could be detachment or hemorrhage. Okay. And there is something called ocular decompression retinopathy. Okay. So that's why if you have a patient with high IOP, you have to do some preventive measure before entering the eye. Like what? So suppose they have a patient, glaucomatous patient, and you are planning to do a trabeculectomy, which is a penetrating eye surgery. So you are going to perforate to make an opening in the eye. So before the surgery and during the surgery, you do some maneuvers in order to avoid sudden decompression. So
if there are no contraindications, I can give IV mannitol,
yes,
or acetazolamide.
So topical and systemic like mannitol, and during the surgery itself. So during the surgery itself, it's still the IOP is like 30 millimeter mercury. You can do like paracentesis before the trabeculectomy. So the step where the eye is open is trabeculectomy, right?
Okay.
So you know the steps of Trab. Euclidean conjunctival flap,
Yes,
and then scleral flap, and then trabeculectomy.
and anterior chamber
So
paracentesis.
you can start before trabeculectomy by doing like guarded paracentesis to slightly decompress the eye, and also massage before the surgery. Ocular massage can decrease the IOP. Okay. Again, this is a hypotenuse eye.
This is a color fundus photo of the left eye. The picture shows a dome-shaped elevation,
Yes.
mainly in the nasal quadrant. So probably it's a choroidal detachment.
This is left eye. So you have nasal choroidal detachment. Is there anything else? So if you notice,
the discus, there's a line slightly edematous. Okay.
There's a line here. Can you see it?
Yes, ma'am. Yes, ma'am.
And this is his ultrasound. So it is almost the start of kissing choroidalis.
Correct.
So don't miss another time. Sometimes the photos there is like something obvious. So you are focusing on this obvious sign and you miss a subtle thing beside it. So try to like visualize the image, every part, in order not to miss anything. So actually there is a slight choroidal detachment also in the temple. It's not involving the macula, but it is in the temporal area. And what's the difference between this and this? This is almost a kissing choroidalis, but this is a choroidal detachment or something more dangerous.
There's hemorrhage also associated with this.
So compare now. This is like equilucent here. This is dark. So this is just serous choroidal detachment. But here we have some heterogeneity. This is a blood. So this is actually suprachoroidal hemorrhage. Okay?
Okay.
All right. Fill in the gaps. Post-trap, high IOP. And we have shallow AC. What are the possibilities?
High IOP with shallow AC, it could be a pupillary block, malignant glaucoma, suprachoroidal hemorrhage.
Okay, wait. What is the other name for malignant glaucoma?
Aqueous misdirection syndrome, ciliary block glaucoma.
Okay. So aqueous misdirection. So if you are discussing such a case in front of a patient, don't say malignant glaucoma. Please say aqueous misdirection. Okay.
Okay,
so high IOP with normal depth AC, or sometimes in some books they write deep AC, but actually deep it means normal depth. So what are the cause of high IOP after trap with normal depth AC?
Failure of filtration.
Excellent.
The block.
Yes.
Blockage in the.
So fill the blip, whatever the site of the blockage. Okay. So filling a blip or fill the blip. Okay. Coming to the next, we have shallow AC after trap. What are the causes with low IOP? Shallow AC with low IOP after trap.
Bleb leak.
Bleb leak.
A wound leak.
Yes,
ciliary.
sleek. So sleek.
Okay. Okay. Ciliary body shutdown.
So overfiltration. Don't forget overfiltration.
Overfiltration. Okay.
Overfiltration means suppose the sclera fab is loose or one of the suture is broken or something. So overfiltration, bleb leak, and ciliary shutdown. And shallow AC with high IOP actually mentioned in this. You already mentioned in this tab on this table. And how about low IOP with deep AC? There's nothing called. Actually, this is our goal. Yeah, this is our goal to goal after surgery to have a normal depth anterior chamber and relatively IOP in comparison to the pre-operative. All right. So we have a lot of operations in glaucoma. You have to know the indications and the contraindications, the techniques, and as you noticed right now, we were focusing on the complications. So sometimes the question is all about the complications, how to avoid the complication. Sometimes the question about how to avoid the complication, how to recognize the complication, and how do you treat the complication. So during your study, don't study the complication like enumeration, like titles. You have to know some information related to the complications. How, at least, how do you manage? How to recognize? Okay, and since you are going to the final, so you have to practice all these things by speaking. Don't use writing, or at least you can write, but then practice by speaking. Again, glaucoma is a big chapter, so you would never escape the glaucoma in the exam. And we have medical, laser, and surgical treatments, and we have combinations, and we have a lot of surgeries. We have penetrating surgery, non-penetrating, mix and drainage devices like tubes, psychodestructive, and some surgeries for pediatrics. So you have to study all these. All right, Dr. Tamanna, before I end with you, we have a break with you, a mini break. And it's a kind of question. It is an optics question. Because I'm interested in optics, actually. So one of the complications of post-trab, in early post-trab, shallow AC, right?
Yes, ma'am.
What is the effect of shallowness of AC on the refractive state of the eye?
Myopic shift.
Myopic shift. Easy questions. Okay. So some patients, like presbyopic patients, can see well after surgery because this myopia would help them in reading. So they might not complain of near problems. They actually may be happy by their second sight. Okay, so shallow AC causes myopic shift. Excellent. Okay, and luckily we have Professor Vijaya, and she's an expert at general medicine and in ophthalmology as well. We have two supervisors, Dr. Benny. So this is actually one of the previously asked questions in general medicine. So you have now an Egyptian examiner with a different accent. So try to focus because sometimes the general medicine question is in form of scenario, okay? But don't worry, Egyptian examiners speak slowly. So you have a 60-year-old male presented with abnormal behavior, sweating. The patient was a non-diabetic and he was on glimepiride 1 milligram and extended release metformin 500 milligram. How do you manage this case? First of all, if you want the examiner to repeat the question, you can ask that kindly please repeat the question.
Okay. So my patient, since the patient is already a diabetic, non-diabetic, and on anti-diabetic medications, and presenting with adrenergic symptoms like sweating, palpitation, as it is mentioned, and also some neuroglycopenic symptoms like confusion. So I would like to label the patient as hypoglycemia once I draw the blood and check the blood glucose level by a glucometer, if the blood glucose level is less than 70 milligrams per deciliter, then I would label the patient as hypoglycemia.
You found the blood glucose level 50 milligram per deciliter, 50.
Yeah, so then it is a little advanced, the mild, moderate, the severe form of hypoglycemia. The ranges are less than 70 milligrams per deciliter to be stated as mild. Between 50 to 70 is moderate, and less than 50, it is a severe hypoglycemia.
Okay.
And at the same time, I would also put the IV line in the patient to draw the blood and check for the blood glucose level. Along with that, I will check serum insulin levels and C-peptide levels as well. Now, since this patient is already a known diabetic, it's probably because of the anti-diabetic medications that the glucose has decreased, either because of the glimepiride tablet.
Okay, but
So I would...
1 second, Dr.
Yeah.
Vinny. So the
Yes.
patient was not on insulin. The patient was on.
And the patient was not on insulin.
Yes.
Okay. Okay.
So I don't think that you will need to assess the insulin and the other one.
Okay. Yes. Yes. Yes.
Peptide. But if the
Yes.
history is like vague,
Yeah. Yeah.
I don't know if Dr. Vijaya will support me, but sometimes more investigations are not recommended because we try to be conservative in investigations. But by the way, this is good. Actually, it shows the examiner that you know all the other causes of hypoglycemia. But here the history is obvious because of combination of oral anti-hyperglycemic drugs. Okay, so keep going.
Okay. The management of hypoglycemia mainly depends whether the patient is conscious or not conscious. Now, in my case, ma'am, can I get the symptoms again? Is the patient confused?
There is disturbed in the level of consciousness with abnormal behaviors.
Yes. Okay. So since the patient is disturbed and the patient is not so conscious, then I would prefer to give a patient straight away IV glucose. 100 ml glucose of 20% glucose, or I can also give intramuscular glucagon 1 milligram.
So you are giving the patient what? Glucose 20%?
Glucose 20%, 100 ml of 20% glucose.
So what is your reference, Dr. Vini?
Ma'am, I went through a lot of books. One was the Harrison Manual.
So you don't need to go a lot of references. Just to check one reference, like trusted reference and recent reference. That's it. So this is a general medicine. So there is no time to check a lot of references.
Yeah. If I'm not able to find the IV line, I can also give intramuscular glucagon 1 milligram.
And then?
So there is a 15-15 rule that I need to check the glucose again after 15 minutes to assess whether the blood glucose level has increased to more than 70 milligrams per deciliter. In case it is not increased, I would like to repeat the same thing again.
Okay. All right. Now the patient regained his consciousness and he is like fully awake. So what is the next step?
If the blood glucose levels are more than 70 milligrams per deciliter, then again I would like to act a long-acting glucose, because sometimes if the patient was just on glimepiride, ma'am, or no sulfonamide. Okay. So if the glucose level...
So 1 second. So glimepiride is one of the sulfonylureas, and sulfonylureas stimulates the insulin release. So it sounds like they are like insulin. Okay.
Yes. So it will take a long time. So we need to give a prolonged treatment for at least 2 to 3 hours.
So you keep monitoring. So you keep monitoring the patient for a couple of hours, even after regaining his consciousness, because there might be a risk of recurrence. Okay.
Yeah. Yes, ma'am. Yes.
Okay. So, Dr. Vijaya, do you have any comment on this answer?
Dr. Ghada, as far as I know, I'm not a MD physician, but if the patient is on sulfonylurea, then glucagon has to be avoided
Yes.
because there is very little glycogen to be mobilized in the liver. It's not answer glucagon at all, just limited to IV glucose or dextrose.
Okay.
Okay, okay, ma'am.
So actually, this is written actually. So thank you for reminding me by this. So glucagon is contraindicated if the hypoglycemia due to sulfonylureas or alcoholism. Okay. So
Yes, the
Dr.
glucose.
Vijaya mentioned dextrose. So according to my reference, it is written that we give this patient dextrose 10%. So that's why I was confused because this is not my specialty.
Okay.
So in my reference, it is dextrose 10%.
I mean, one book, I think in Harrison itself, I read that dextrose, they have stopped giving it now.
So
They used to give it earlier.
So dextrose 50% is no longer because it causes thrombophlebitis. But
Okay, okay.
dextrose 10% is okay, according to my
Okay.
reference. Because we are speaking out of references rather from experience right now.
Okay, ma'am.
So you have to keep monitoring the patient, check the glucose level every now and then. Actually, we have two important points in the treatment: to treat the acute hypoglycemic state and to prevent recurrence. Also, you can add that you have to teach the patients and the relatives about
Yes.
and like to keep it checking with the physician to adjust the dose and so on, like education.
Yes. Yes, education to the patient. Yes, ma'am.
So actually, this case was taken from this journal, from this article, and they used, by the way, dextrose 10%.
After consulting an expert in emergency medicine, it turned out that glucose and dextrose are different names for the same thing. And we have different concentrations, so it depends on the severity of hypoglycemia. The more severe the hypoglycemia, the higher concentration we should use. And that's why there is some discrepancy in the references regarding the amount and the concentration. And that's why it is always said a little knowledge is a dangerous thing.
You can also add, you have to check the level of the consciousness. You asked me about the consciousness, but you have to assess the level of consciousness, and you have to, since it's emergency, you call for help because you may have you need a team, one to check the glucose, one to give the medication. And it's not bad. It's also recommended to say ABC. So, you know, A for airway, B for
breathing, and
C circulation. Perhaps the patient, some gives oxygen, like a supportive treatment. And we have D. So we have A, B, C, and D. Do you know what D stands for?
No, ma'am.
Drug.
No,
so generally
drugs.
You can say drugs. Like here, you mentioned glucose 20%.
Yes.
Okay.
Yes.
And we can also add this mnemonic. Never ever forget glucose check. So whenever you have any patient with disturbed level of consciousness, you have to check the glucose, especially if the patient is diabetic. So I gave you a scenario of this patient, but there are a lot of scenarios for hypoglycemia. So the scenario may be about diabetic patient and insulin, or any cause for hypoglycemia. So we have different scenarios, and definitely you know this.
Excuse me, Dr. Ghada.
Yes, Dr.
Ziad.
Ziad, yeah.
Regarding the previous slide for ABC in emergency, I have some experience in my exam. I told it was British examiner.
Yes.
I told them ABC, he was asking about a case of fits seizures. And when I told him ABC, he was some sort of angry. He told me it's old, it's now CPA. I don't know.
Yes. So
and he was very angry because I'm said that. I told him I know it ABC, He told me no updated it's CBA.
So actually, I attended an advanced life support during my preparation. Like was like in 2006, and actually they said this C should be before B, but we used to say ABCD because this is like an alphabet order. And by the way,
And also in my reference, as you told before, also it's written in my reference, but it's not updated, I know, but it's written ABC.
Okay, but I think this is not a failing answer. I mean, you may be pressed on his nerves and he got angry, but at the end, the examiner must treat you fairly.
No, I am telling you to the future. I don't know if I have the same question. I am telling CBA or ABC.
No, you have to say CB. Like circulation is
First.
So I don't know if we can say first, because all should be assessed
All
at
are
the
important.
same time, because you need a team. So the emergency team, that's why the first thing is call for help, because you won't want to check the pulse, want to check the blood pressure, want to check the breathing, and so on. So we like to say ABC because this is an alphabet order, but I think all must be done together. We don't have an expert here, Dr. Ziad, sorry for this.
Okay, no problem.
And this reminds me by one thing. Don't say mnemonics, because this is a kind of mnemonics. So don't say, I will do ABCD. Don't say like this. Say, I will check the airway, the breathing, circulation. So never say mnemonics. Never ever say mnemonics. Never ever say analogies, like analogies, any analogies in ophthalmology. So back to my comment. So D4, this is a kind of mnemonic. Don't say D. So D, just a reminder of the drugs, and to check, and do not never ever forget glucose check.
Yes.
Okay. So general medicine is also always tough. Let's see what's next.
Again, after consulting an expert, we realized that we keep the same order ABC while assessing the patient. So this is like a general rule for assessing any patient in the emergency room. But whenever we have a case of cardiac arrest and we are going to start resuscitation, CPR, we reverse the order to CAB. So the priority comes to the circulation.
So you have to know, and you definitely know, Dr. Benny, because you answered correctly, that you have to know the symptoms of the hypoglycemia, and it passes through 3 stages, like sympathadrenal overstimulation. That's why we have palpitation, tachycardia, and so on. And then as the glucose level goes down, we have some neuro manifestation like confusion, convulsions, and finally coma. So the case scenario may be in the form of coma. And here is an infographic. Again, this is from Google's. It summarizes all things. Sometimes this type of flashcards or images helps you during studying. And this is actually for like general people or lay person. So that's why they mentioned only glucagon injection, because at house you don't have the facilities to do IV perhaps, so they mentioned only glucagon. But again, it's contraindicated with sulfonylureas and alcoholism. And so diabetic comas in general is one of the most of high-yield questions, very commonly asked with different scenarios. So the most important, of course, is DKA and also the hypoglycemia. And there are also other types of comas, but they are not as important as DKA and hypoglycemia. Okay. And Dr. Deepika is still not there. This is for recording version, so I will show the one of my videos for Viva. Definitely in this video, I was making mistakes, a lot of mistakes.
You will find the video as well as the critique and the model answers of the questions asked at the end of this video.
And there is a critique. You will find it in the video description. But I have to comment on one thing. The question actually is one of the previously asked question in Bangalore, 2020, and it was about cavitary lung lesions. Again, there is mnemonics, so never mention mnemonics. It just it reminds you about the causes. And you know this mnemonic, I learned this mnemonic from Professor Moto. Vitamin C, so V for vascular, T for trauma, M for metabolic, and for so right now I can't recall all the abbreviation. But first, never mention mnemonics. Second, try to keep the order. I mean, if you have a list, mention the most important one. So when it comes to cavitary lung lesions, the most important one is tuberculosis. So tuberculosis actually under the title of infections. So here in vitamin, it is the second, but it should be in your answer is the first, because this is important, and the cancer. So so cancer is neoplastic, so the N is here at the end, but so mention the most common and the most dangerous first. Okay, so while you are listing causes, mention the most common and the most dangerous first, and try to be relevant. So I mean, we have something immune like sarcoidosis, but sarcoidosis doesn't cause cavitary lung lesions. So sarcoidosis can cause lung lesions, but not cavitary. So sarcoidosis is not among the list. Okay, and one more thing. And there is another mnemonics like this I found in my national national students. They mention acquired congenital traumatic trauma, like this neoplastic. So one of the most commonly asked question: what are the cause of proptosis? And one candidate says, for example, tumors, and stopped. So you have to give examples. Like what? Tumor like what? Like what orbital tumors that can cause proptosis? So don't say titles. This is not an answer. If you say we have traumatic causes for proptosis, what are the traumas that can cause proptosis? What are the tumors that can proptosis? So you have to mention the examples under each heading. Okay. Now I'm finalizing my presentation by a quiz, and actually I mentioned this quiz before in WhatsApp, and you nailed it. So again, the aim of this quiz was to think. So we have like a black straight line, and we have an arrow. So there is a guide, there is a clue here. There is an arrow. Okay. So it points to something wrong. So it could be something wrong or sign. So actually, this is not an eyelash, because some said it is an eyelash. So eyelash, actually, it is a suture. So it's a suture, and it should be black, because this is a suture lysis, and suture lysis by argon. So argon needs a black suture, because the argon needs a pigment, to be absorbed and to be in order to be cut. So actually, this is a suture, and also they aim to appreciate the level. So some say this is actually, and I posted this quiz in another group, but some say this is like a dropped IOL on the retina. Definitely, this is not the retinal blood vessels, unless we have a vascular lesion. But this is not the arrangement of retinal blood vessels, and the background here is like white or opaque. But in fundus, the background is like reddish. So the level is not intraocular, it is actually episclera, or let's say subconjunctiva, or it's like on the ocular surface in the upper conjunctiva. And actually, this is the view through a lens. One of the lens used for laser suture lysis. And here after the suture had been cut. And this is another view using here a Hoskin lens. And we have other lenses like Blumenthal and Rich lenses. And we went through this answer before. So now, as you can see, this photo is not clear because your eyes not get used of this picture. But if you think it is actually a part of the butterfly, and that's why we need to see a lot of images. Try to like scrutinize each details, like try to visualize everything in the image. Kandinsky is full of images. Don't look at the comments below the image. Try to expect or guess at the findings and look at the comments. And sometimes the comments don't mention everything in the photo. So try to elicit more signs. Try to be elaborate, more descriptive while visualizing images. All right. And my last advice, one advice that I want to end my presentation with this advice. So be attentive to the question asked. So much misunderstanding happens because the listening side of your side is ignored. So for example, when I ask Dr. Tamanna, what are the complications of Trab? This question is different from another question, what are the post-operative complications of the Trab? Or what are the late post-operative complications of the Trab? So be attentive to the question. Whether the question is about what are the signs in the image or what are the differential or what are the diagnoses, okay? And so listen carefully, clearly, and effectively to the asked questions because poor listening can result in costly mistake. And if you have a problem with the accent or anything, you can politely ask the examiner to repeat his question. Last, the homework. Whenever you feel that you have to revise anything, we already mentioned many points. You have to study and revise them. Okay. So take notes was a good practice while watching any presentation, because just watching a presentation is like an entertainment. But after you finish the presentation, you study. This is now you are getting the maximum benefit of this presentation. So we've done the end of this presentation. And thank you for your attention, and thank you for joining me. And thanks, Dr. Professor Vijaya, for being with us today. And I will keep the meeting for a couple of seconds. So if you have any comments, suggestion, criticism, or if you could mention what's the most thing you liked in this presentation, you can type in the chat box. Okay, we are good to go now. Thank you once more and see you next time. Okay, again, keep studying, keep learning, and have a good day.
Good afternoon. I'm Dr. Muhammad. You have a case of hereditary lung lesion. What's the differential diagnosis?
Hereditary lung lesion. The most important cause is tuberculosis, and I think lung cancer can cause the hereditary lung lesion.
Anything else?
No, I'm sorry. This is what I will remember.
If we have some bronchoalveolar avulsion of this patient and it was positive for resilience and stain, what's your diagnosis?
It's TB, tuberculosis.
Tuberculosis. How do you treat this patient?
I would like to refer this patient to a physician who are specialists in treatment of tuberculosis.
Do you know some of the drugs used for treatment of tuberculosis?
Anti-tuberculosis drugs.
It's like what?
Like rifampin, and Samy.
Okay.
I'm sorry. sorry, this is what I remember.
Okay, any of these drugs has some ocular side effects or ocular affection?
Yes, of course. I think one of them can cause optic nerve affection.
Yes, can you elaborate more?
I remember, I think it's ethambutol can cause optic nerve affection.
Okay, thanks also.
Okay, والله good.
Yes, actually you're doing fine, but thanks also. Thanks.
Okay, you remember me? I was working with in your hospital.
Yes, of course, but thanks also for your attention. Thanks.
Okay.